She does have depression, she feels anxious, and generally doesn't want to go anywhere because she's always in pain.
My aunt got an injection, or someone I know got an injection, and they're paralyzed. And I'm like, that's not true. Like, the likelihood of that happening is so low that I don't even believe you.
Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. For decades, chronic pain was treated with a prescription pad. But modern medicine is shifting toward procedures that can actually interrupt pain signals instead of just numbing the pain. And yet, many patients still do not know these options exist. Today, Dr. Tiffany Russ and I are talking about the powerful procedural tools that can reduce opioid dependence and give patients their lives back. Dr. Russ, welcome.
Thank you so much, Dr. Takem.
So let me tell you a story of a patient. As you know, I love stories. So she's 68 years old, deals with chronic pain, and that chronic pain has led to high blood pressure. She does have high blood pressure, but in the office it's always high because she's always in chronic pain. She does have depression, she feels anxious, and generally doesn't want to go anywhere because she's always in pain. Now, she has long resisted procedures because of what other people have told her. They will stick you and go into your joint, and then it will hurt, and then those things don't work. And then, doctors just want to make money off of these things. The whole complex of conspiracy theories out there about how we doctors are in cahoots with, the pharmaceutical industry and everybody else to make patients suffer. So I had a conversation with her about the efficacy of interventions to relieve pain. She did not believe me. So that's why I decided to bring you on this show to tell us why patients are reluctant to get these procedures and how these procedures are much more effective than narcotics in long-term pain relief. The floor is yours.
Thank you. Yeah, I'm surprised at how many patients come to me with stories of, my aunt got an injection, or someone I know got an injection, and they're paralyzed. And I'm like, that's not true. Like, the likelihood of that happening is so low that I don't even believe you. I don't know what happened. And so they come with that fear, and that kind of shapes their whole perspective, and it makes it hard for them to hear, what I'm trying to say. And I say, interventional pain is not about like medicines. That's kind of secondary for me. What can we do from a procedure standpoint? And it's not just nerve blocks. It's not just epidurals. We have a lot in our toolbox now, and our field has kind of grown even over the last 10 years. And so what we can offer people, from tumor ablation therapy to intrathecal or pain pumps that deliver medicine for patients constantly, to devices that interrupt the brain's ability to sense pain, to nerve transections, to burning of certain nerves, to significantly reduce pain. There are a lot of options, and it's not just kind of the basic epidurals and nerve blocks. And so it's an exciting time in our field to really help patients.
So let's start with nerve blocks. What do nerve blocks do biologically?
Yeah. So I tell patients, when you go to the dentist and you're getting something done, your dentist puts some medication in your mouth. It's a local anesthetic or a numbing medication that temporarily interrupts your brain's ability to sense sensation at that area for a couple of hours. And so that is a similar concept, right? The nerves in your body control certain joints, right? And I say, hey, right now, those joints are angry and inflamed, and they're telling your brain we're constantly in pain. So me putting numbing medication is a way to interrupt your brain's ability to sense pain coming from that joint temporarily.
So the pain is there, but you don't feel it.
In a sense.
Yep. It's like speeding on the Beltway and not getting a ticket.
Yes.
Something along those lines.
That's exciting.
Okay. So let's go next to radiofrequency ablations. How do those work? Because those are the things that, when patients come see me, after seeing a pain management specialist, they bring these pamphlets with all these pain procedures listed, and I have to explain to them what they are. So can you explain to the patients, what is a radiofrequency ablation? How does that help their pain?
Yeah. So like we just talked about before with nerve blocks, right? So let's say you have really bad arthritis or inflammation in your back of certain joints. It causes pain that just stays in your back. It doesn't travel. It's worse when you're twisting, worse when you're turning and bending. If we do a nerve block and you say, hey, Dr. Russ, I did not feel the day-to-day pain that I had for beautiful 8 hours. And I went and I cooked and I cleaned and I did cartwheels and I felt amazing. I say, hey, you know what? We're going to do it one more time just to make sure it wasn't an accident, that you got significant benefit that day. If so, we get to move on to the ablation. And that's where we take a device that heats up to a specific temperature and temporarily kind of zaps those nerves. And all they do is tell the brain how that joint is feeling. It does not participate in your ability to move your arms, move your legs. It doesn't participate in sensation. So we're able to temporarily zap those nerves and they don't grow back for about a year. And so you kind of have a year of pain relief.
Let's go to the next one, which is the most popular, I believe. The ones patients get all the time and have the most questions about, epidural steroid injections or other injections, but that involves the epidural space. How do those work?
Yeah, so it involves me putting, again, powerful anti-inflammatory medications, which are steroids, into a space in your back that directly contacts those nerves, right? So sometimes I say when nerves get irritated or inflamed or angry, if you will, it can cause burning pain, pain that shoots down your arm or shoots down your legs, or nerve pain can be an itching-like sensation. All of those are due to irritated nerves. It could be a disc that's pressing on a nerve. It can be an arthritic joint that's kind of pressing around nerves as well. And so putting medicine in that space to calm down those irritated nerve roots is what helps with the pain.
I'm going to shift gears and go to another fan favorite. Patients always come to me and say, Doc, I feel this pain in my foot. And I looked up the symptom. They said it's neuropathic pain. Can we explain to patients what's the difference between neuropathic pain and inflammatory or arthritic pain, which is that has a degenerative basis?
Yeah, so when I think of arthritic pain, I think of dull, achy, stiffness, maybe worse if you've been sitting for a long time or when you wake up in the morning and you start to move about. Nerve pain is a burning sensation, an itching sensation, or maybe a tingling sensation. Inflammatory pain could be a combination of arthritic pain because arthritis is a fancy word for inflammation. And so that could be an underlying, I say kind of a wear and tear process of us constantly using our bodies, which is a good thing in a sense, but it can lead to inflammation, which can lead to pain.
So this brings me to another question, because the purpose of all these procedures that you just mentioned is to restore the patient to a certain degree of functionality. But the question that I always get from patients is, are we just masking the underlying problem and just treating the symptom? How do we measure functional outcomes in pain management and help the patient understand that functional outcomes are really the things that they should be looking at rather than fixing the underlying problem short of getting a new joint?
I agree. That's my focus from day one. Okay. We're kind of setting and reframing expectations. I say the point is not to eliminate the pain. The point is to reduce it so that you're doing the things that you enjoy and activities that you enjoy. And yes, like me putting medication in the space doesn't change things structurally, but it helps with the symptoms. And if you can have better quality of life, improved function and outcome, better mood, then that is a win. Okay.
So the problem that needs to fix is restoring the patient to enjoying their life, to a great quality of life. If I can understand, and if I were a patient driving to work and listening to this podcast, my focus therefore should be on being able to maintain a high quality of life rather than searching for the final solution to this pain problem, short of getting a new back, a new spine, or a new knee.
I agree. Absolutely. That should be the focus.
Because I told the patient once who I explained, Doc, so how can I make this pain go away forever, the low back pain? I told him, well, if you could go back to being 25, the pain will go away forever. But neither you nor I can do that.
No, we're always moving forward, right? Things are either staying the same or getting worse, and that's okay. We have to find ways to adapt and continue to be flexible despite the discomfort.
Is it safe to tell a patient that as you get older, a joint hurting is inevitable?
Not necessarily, because I have patients who are in their 60s and in their 70s, and they may have severe findings on imaging, but they don't feel those symptoms. So I can't necessarily say that aging and the degenerative process is directly going to cause pain and dysfunction.
But we can safely say aging leads to degenerative joint disease.
It does, yes.
It will not necessarily translate into overt pain for the patient, but it's there.
Absolutely.
Part of the aging process.
Unfortunately.
I should get my knees and joints checked.
Yes.
All right. So it's been a pleasure talking to you, Dr. Russ. Thanks for joining me again on another episode.
You're welcome, and thank you.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.